Thanks, John, and thanks, colleagues. So staying in primary care then for a little while, I'm going to look at commissioning in primary care. So I'll give an overview of policy drivers around commissioning, then focus a little bit on what types of research. So not specific projects, although I will bring in a couple of examples. And then a little thought around impact on policy and practice, and also what that sort of impact means for health services research and how we might use that in terms of thinking about future funding or our own development as we go through our careers. So in terms of commissioning then, well, primary care-based commissioning, it's been a policy concept that's been around for over 20 years in jurisdictions such as the UK, and more recently in Australia through the primary health networks. Whilst there's no single definition of commissioning, at its simplest, commissioning is the process of planning, agreeing and monitoring services. However, securing services is much more complicated than securing other goods, and the complexity, diversity of the health sector and the services delivered is unparalleled to any other sector. So that makes it complicated for those doing the activity of commissioning, and makes it even more complicated for us as researchers when we want to look at commissioning activity. And I'll come back to that later. So commissioning is not just one action, but many. It ranges from health needs assessment for a population, through the clinically based design of patient pathways, to service specification, contract negotiation or procurement, with a continuous focus on quality assessment. I should say in the UK, it's been the main place for the commissioning activity. The UK commissioners currently hold around 60% of the NHS budget and used to hold about 80%. So in UK terms, it's big business. So then, what have been the policy drivers for commissioning? Whilst these have varied across countries, they do tend to relate to some common themes. They relate to pressures of increased demand and increased costs of healthcare, so the actual dollar that we put in and the demand that continues to increase. Focus on strengthening primary care and keeping people out of hospitals, and there's lots of discussion whether or not that would be a cheaper option, and there's the thought that it wouldn't, but actually it may be what patients want and will be better for communities. Increase the competition in primary care provision, so having a more market-based focus with a view of increasing efficiency and quality of services. A separation of provision of public service from commissioning of services. And there's an interest in investment and disinvestment decisions and cost effectiveness and value for money. And these are important, I think, as researchers, because what's the drivers for policy is often the drivers for the interest around the research. So governments will tend to fund studies that are focused around some of these areas. Likewise, local commissioners are also interested in funding activity and research that will demonstrate they've achieved some of this, or in fact, if they've not achieved it, why not, and what can they learn? So a real focus is on the right care, right time, right place, as John put it in his earlier slides. Next slide, John, please. Thanks. So if you think about the research into commissioning, there's been actually lots of it, and there's a few key authors or researchers that have been involved in that. Judy Smith recently spoke at our conference earlier this year, or last year, sorry, and she did a lot of work in that area with colleagues such as Chris Ham, Nick Mays, and myself, Helen Dickinson. There's lots of research in this area, and that's been going on for some years. In terms of types then, there's been large-scale and small-scale evaluations that have been funded by governments. The local commissioners themselves have funded lots of activity. Universities have seed-funded money into this area. And then there's been large government-funded research, mainly from the UK, the National Institute for Health Research and its predecessor, SDO. So there's been some large grants funded that have really tried to look at the implementation and outcome of commissioning, particularly in the UK NHS. And there has been some studies in Australia that have been government-focused pieces of evaluation that have tried to look at primary health networks and their predecessors, Medicare locals, in terms of how well they're doing it in terms of the policy reform. And there's been studies from the broader policy perspective that have looked at the process, as I say, and shifting policy focus and what impact or success commissioners might be having on the key drivers. There's also been quite a focus on looking at some of the effectiveness and cost effectiveness of the commissioned services. So individual services that may have been commissioned by our primary health networks, for example, could be around older people services, child services, mental health. So there are some discrete projects that are not necessarily just about commissioning in its broadest sense, but are actually to help inform commissioning of services and programme development. My own work's involved exploring the effectiveness and cost effectiveness of commissioned interventions in primary care. It's often difficult to undertake such activity. It's hard for a number of reasons that I'll come on to unpick a little in the next couple of slides. Not just it's difficult, but also it's difficult to get the engagement of people to want to do that. So I say we'll come on to that later. Next slide then, John, please. So in terms of what the actual policy evidence says then, just before I move on to that, just be good to think about what are the types of research methods that have been used. And Jackie has outlined some of the qualitative sort of type studies, and that's what's tended to be used here. I mean, it does depend on the aims and objectives of the research, as it should, but the implementation and process evaluation type activity tends to use qualitative methodologies, case studies, interviews, and observational studies. They've often been very much focused, not, again, as Jackie mentioned, not really with consumers, but with the actual commissioners of services and the stakeholders involved in that. There's been a smaller number of quant studies. These are tended to be more survey-based and more descriptive stats rather than anything more sophisticated, and with a small number of mixed method studies. So that's the policy and process and implementation. In terms of what this type of work has found, we found that it's quite complex. So it's complex in terms of trying to untangle what's actually happening in commissioning. There's often overlaps. This policy overlaps with many other policies. The commissioning is sporadic, it's irrational, so it's quite difficult to then impose some sort of rational research perspective onto the actual commissioning process. It's been important to have complementary policies and incentives that focus on efficiency, value for money, accountability and quality that could be used to engage and incentivize clinicians and providers. John mentioned activity-based funding, and that came up quite a lot in research, that's been very important to engage the hospitals, which is for the UK, services in the hospitals are commissioned by primary care. So it's been an important way for primary care and primary care commissioners to be able to act as a carrot and a stick. So we know what activity you're doing, it's more transparent, and we will fund for this, we won't fund for the other. Clinical leadership and ownership, it's been integral to achieving reform and improved performance. This has come through in other studies that's outside of commissioning that need to engage clinicians as they're the provider of services. And for some work that I was involved in, where the actual barriers were where clinicians had not been involved in some of the early decision making. So it's not just to bring them on at the end when the decision's made, but actually to include them early on in any decision making forum. And it can be hard to do. And if you look at the reform in the UK, the move to local clinical-based commissioning rather than primary care-based commissioning, there's a subtle difference there, was very much around the evidence trying to engage clinicians into the world of commissioning. Previously, they've been sat on the outside of that and impacted by what the commissioners were asking them to do, but weren't really very much in terms of leading that. It was just one or two clinicians. So the idea of clinical-focused commissioning was bringing general practice to help shape and inform these decisions. There's been a focus on priority setting tools to support the decision-making process, and there's been lots of this and lots of development around economics and priority setting. There's been a criticism in the literature that's been very much technical, and whilst it's important in early days in commissioning, especially in UK, there was a really limited relationship work, which was equally important. So the whole stakeholder engagement and bringing people along to on this commissioning journey was very limited. It was more on operations and technical aspects. Okay, John, next slide, please. So in terms of the outcome-focused research, well, outcome-focused research tended to be very limited. As I say, the outcomes have tended to be much lighter touch survey, and that's nothing wrong with doing a survey, but it's been lighter touch rather than the more focused using administrative data or patient-reported outcome measures to really look at what difference or not commissioning may have made. And part of this is because it's just so difficult to do this in terms of the commissioning policy. It's really challenging because there's so many confounding variables. It's hard to say that commissioning made that change. Was it the commissioning? Was it the activity-based funding policy? Was it stakeholders in there doing something slightly different than nothing to do with commissioning? Was it partnership, the policy around partnerships? So it's really hard to really focus this on cause and effect. So I think that, and for me, that's why researchers have tended to shy away from that. What has tended to happen, though, is that we've had more small evaluations, as I've said, around more localised commission programmes than the broader commissioning process itself. And as Judith Smith alludes to here, it is a decade of evidence in terms of commissioning, but it's very limited in terms of the impact of the agenda itself. Okay, John, next slide, please. So in terms of impact then, what does this really tell us, and what does the impact tell us? Well, what we've seen in terms of impact is that it's difficult to really measure the broader outcomes. I was involved in a particular study that looked at decommissioning of older people's services, and we did manage to use some patient-reported outcome measures and patient-reported experience measures. It was part of a big study to look at over a 2-year period the impact of the closure of the older people's home and the resettlement of older people into other services. And we managed to do this over the 2-year period to look at the initial onset of the move and how traumatic that was to those individuals, through to later down the line, 2 years' time, when there was very limited impact. In some places, patients or service users actually had improved in terms of their outcomes. So that was a really interesting project that was about the commissioning or decommissioning process, but it was specific to a particular intervention or program. So in terms of the impact of that and what we learned, well, there was a couple of things that are really important, I think, that came through. One was around making sure you capture baseline, so making sure that you have the baseline evidence and that you can actually use that baseline then to measure going forward. And often the commissioning activity that I've been involved in, people call you in retrospectively and ask you to look at the data they've collected, but they never collected baseline, so you can't see at all how they've travelled. So for this particular piece of research, we were involved early, in fact, ahead of the decision itself, which was really good. What this did was allow for the researchers to really inform and shape the research aspects and to have a greater understanding of the project. The other important bit, I think, for me was having senior researchers who understood some of the ethical challenges in conducting this research. Some of these individuals and participants had dementia, or both the participants, staff, clients, families. It was a very difficult time. So it's understanding some of those sensitivities and having that senior research support, I think, was important. In terms of the impact then, and that particular project, the impact was interesting in that we then got commissioned to do additional work for the UK government and for the Prime Minister's office, where there was actually issues around other services being closed, public sector services. So we developed guidelines. Also, in terms of the impact, we managed to get invited onto NICE's, the National Institute of Health and Clinical Excellence, which is the overseeing body about whether or not things should be prescribed or used within the NHS funding bag. And we were invited to develop national guidelines around disinvestment and investment decisions. So you can see that can have a knock-on effect in terms of what you're involved in, but also in shaping future policy and practice. Going back to the broader commissioning, evidence from research used in government, there has been lots of evidence from research used in other government guidance. The research from the UK has travelled to Australia and is used in their guidance as well as its own. Researchers have been invited to speak on UK House of Commons Select Committee would be one example that I can think of. And this just shows the power that the research can have in terms of influencing the policy process. And the House of Commons Select Committee is really quite prestigious in terms of helping shape government's thinking. So it's quite an important thing for researchers to be involved in. And I think that just shows how you can influence through the sorts of research that we do. More broadly then, in terms of what does all this mean then, and what's happened in terms of the policy itself? Well, in the UK, it's been a frustration of governments about the slow success of commissioning, and that evidence has not been able to demonstrate that commissioning was successful. What that's meant then is there's been successive reforms, so the reforming and reorganisation of the actual commissioning architecture. I can't go into details, but I'm happy to discuss it another time. But what that means for researchers is often when you're partway through your research project, the whole commissioning landscape changes. So the people you are going to speak to are no longer in their employment and things. So the actual policy response can sometimes impact on live research. I think that's it for me, because I'm conscious that we're close to time and there may be some times for questions. Thanks.
Thanks, Suzanne, and thanks everyone for your session. So I've just put one summary slide together just to try and bring all of what we've talked about together. And so thinking back to Catherine's presentation, is a really nice illustration of the spectrum of complexity that clinicians, health services researchers can go to in terms of using health services research in practice. And as Catherine's example of a pilot study leading to a greater funding and a more comprehensive study. So you can kind of start small but dream big, and oftentimes you'll get there with good pilot data. In the hospital policy arena, I mean, the big promise has been health systems data, and I think over the last 10 years or so, it really has been improving at a much slower rate than many of us would like, but it is getting better, and access to it is improving. As I mentioned, I think patient-reported outcome measures, everyone accepts it as a good thing, but there are costs associated with collecting these data, and so we really need to work out how they can be best used to improve, in this case, hospital, but more generally, health systems performance. And then in the primary care setting, I think both Jackie and Suzanne really highlighted the challenges of research in that area, particularly around outcome evaluation. And I think that's really because you're searching for smaller effects when you're looking in a primary care setting, and data collection is more challenging. So there's more of a focus on qualitative and narrative research, but it's that balance that's important to look at. How do you combine qualitative and quantitative research in that setting to achieve real impact? But I think, as both Jackie and Suzanne illustrated, it's certainly possible to achieve impact and produce good health services research in that sector. So I think we'll finish there in terms of our presentation. There's a few specific questions. If anyone's got any last minute questions, we have gone a little bit over time, but we're happy to stick around if anyone has questions or issues that they'd like to discuss. So one of the questions Callan Fraser-Bell asked for Catherine around the methods that you used in your qualitative data. You'd like to expand a little bit on that, Catherine?
Yeah, we really just used a thematic analysis where we recorded and coded all the responses from the interview. So we transcribed them all verbatim and coded them into themes and coded everything and brought everything together into various themes around different aspects of what factors influence weighting. I noticed Mark had asked a question previously about reading the whole report of the RCTs. I've got a little list of references for the papers that will describe all of this in more detail if people are interested. I'm not sure what's the easiest way to disseminate that. I can just cut and paste a list into the chat section. I don't know if that will actually work, but or else if people want to contact Sarah, do you want to, John, is that the easiest way?
Yeah, look, we can put the details up on the website next to the recording of the webinar. So this webinar will be put up there, so we can.
Yeah. I'll just, in the meantime, I'll cut and paste my little list of the few key references into the chat section as well.
Oliver Frank, a colleague of mine here in Adelaide, asked about the expected mortality rates in the analysis of outcomes in New South Wales hospitals in particular, but there's a more general question. So it was the risk standardised mean mortality rate that was estimated. So it's quite a nice way in which they reported it. They showed the impact of controlling or adjusting for different sets of risk factors. So certainly age and gender, but there was a range of other risk factors or comorbidities that they controlled for in that analysis, and we did too in our South Australian analysis. And Mark Owusu asked another question around comparing evaluative strategies of hospital services in high-income countries to low and middle-income countries. And yeah, I think one word we talk a lot about in health services research is context, and certainly the context is very different between the health systems in place in high-income and low and middle-income countries, and so I guess there are some lessons that can be learned across those different contexts, but you really have to take the health system characteristics and the funding mechanisms into consideration when you're looking at translating or transferring research across countries. So, we've provided a lot of examples today from the UK, but from an Australia and New Zealand perspective, there's certainly significant differences in how care is delivered across those three countries. And so you really still have to take consideration of those factors, even when you're looking across what, on the face of it, look like similar countries. So it's something to be aware of.
Just on that, John, it's Suzanne here. Just thinking about the data that's collected across those countries as well, and it wasn't in developing countries, but I was involved in a European study, and it was really hard to compare just because the way the data is collected, different time frames, the different types of data, and to be able to just do something with that was very complicated. So I think it's like that, like you say, the contextual, and the data linked to that context as well.
Yeah, that's right. Okay, well, there's no other questions. Do any of the other speakers have any final comments?
There was just one on the chat room, John, and it was a question around from Snowley. Is there any acute health services that collect patient-reported outcome measures in Australia? I wondered about New South Wales. I think they might be doing that. I know we're starting here in WA at some point, but I don't know if you know of any others.
Patient-reported outcomes. I know that Nick Graves's group in Queensland they've got some pilot work around collecting patient-reported outcomes in cardiology. So I think there's a few pilot studies around, but certainly in terms of mainstream collection, I think it's limited. It's certainly nothing along the lines of what's going on in England.
Yeah, it's not routine, is it?
Not routine yet, but I think it won't be too long before we get there. Yeah. I don't know about New Zealand. Is there any examples in?
No, they're not doing it here. It's not a focus at all. There's patient experience surveys, but not on outcomes.
Yeah. There's a lot of interest. I'm sure it's going to progress, but a lot of research will be going on in that area in the next 5 to 10 years, I think. Okay. Tanya has noted that there's the palliative care outcomes collaboration. So I'm assuming, Tanya, that you're referring to the collection of PROMs through that collaboration. So that's something. Yes. Thanks, Tanya. But yeah, I mean I think that might be a good subject for a future webinar. It'll be something around patient-reported outcomes, or the state of patient-reported outcomes in Australia and New Zealand. That might be an interesting webinar. And that kind of leads on to the last item, which is really to thank you all for attending, but to ask you for suggestions for further or future webinars that may be of interest to yourselves or colleagues. Because we're always looking for suggestions, we're always looking for potential speakers. So please don't be shy and get in touch with us if you've got any suggestions about topics that may be of interest. So with that, as I've said, thank you, and we'll close it there. And Sarah will be sending around an email with details of the recording and its posting on the website. So. Please keep in touch, and hopefully you enjoyed today's webinar. Thanks, everyone.
Thank you.